Welcome to the BMJ podcast. I'm Cameron Abbasi, Editor-in-Chief of the BMJ. This week, we've had a patient takeover of the journal and a patient takeover of the podcast. We'll hear about what the new Labour government needs to think about to support patients.
The answer to the question whether the NHS is delivering can only be given by the people who use health and care services and arguably by the people who work in them.
We'll hear about peer support.
Yeah, I've a lot of, big heart feelings for the clinic actually, for having this approach. And I feel like it's made me much more interested in my condition as well. And, I'm a researcher and I do a lot in the long-term conditions, and somehow just having clinicians that are approachable just makes me more interested and more connected with my condition.
And social participation.
So understanding that universal health coverage is health for the entire population. It's not just for a group. It's not just something that is understood by technicians.
First, let's find out more about this patient takeover of the BMJ. And I'm joined by Emma Doble, our patient and public strategy editor. Hi, Emma.
Hi, Cameron. Thank you so much for having me. I'm at home today, so apologies in advance for any children in the background that you may hear.
That's absolutely fine. Patient and public partnership in action. Tell us about the issue, Emma.
So this was a patient-led issue that we had of the BMJ to celebrate 10 years since the launch of our patient and public partnership strategy at the BMJ. So all of the content, or as much of the content as possible in the issue, was either written by or curated by patients, a lot of our panel members, but lots of different people with lived experience.
Well, that's great. So just to be clear, how do patients and the public usually get involved with the BMJ's content?
Great question. So patients and the public get involved in lots of different ways across all of our journal, really. So they can write for the journal in patient-authored series, such as What Your Patient is Thinking, but they can also be co-authors on lots of other of our article types. So we're seeing that much more in research, in analysis, and in education. They can also be reviewers for us. So we have patient and public reviewers. They are also involved through the governance, through our panel, and our panel really help us drive forward our strategy of how we involve patients and what's the best way to ensure that we're getting the most impact from them.
Yeah, and I mean, one thing you and I know, and listeners may not know, is that BMJ is pretty much the only journal that works with patients to this extent. Why do you think that is?
Yeah, you're absolutely right. I think because it's hard. It's really hard work to do this. I think it requires a lot of commitment. It requires a lot of openness from all levels of the journal to be open to thinking about how to involve patients and to be open to being challenged and thinking more broadly about what we're doing and how we do it. So I think that's definitely one element. I think it's also quite resource intensive. It takes up a lot of time and energy and resource to be able to get patients involved in a journal in a really meaningful way.
Yeah, so we make a strong commitment to working with patients, but I'm sure we could do better, couldn't we?
Absolutely. I think we've got lots of things. We've done a lot in the last 10 years, but I think in the next 10 years, we've got a lot more things that we want to do and much bigger steps for us to make, particularly around the sort of diversity of the patients and public that we work with and that we get involved in our journal. So yeah, lots more to do.
Okay, now let's turn back to the content in this particular edition of the BMJ, and there's a whole range of issues that are discussed, of course, but one of them is social care, and that's something that patients are and the public are very concerned about, but it's one that the government, well, previous governments at the least, haven't tackled in any meaningful way. Did that come up in the theme issue?
Well, certainly when I had a chat with Charlotte Augst, we were chatting about, the new government in place now and this Labour government and what really should be the focus. And one thing that Charlotte was really clear on was that healthcare is so much more than GP appointments and NHS waiting lists. And I think during the election, those were the two things that were coming up consistently. But social care, things that happen much more beyond the kind of walls of a hospital or a GP practice, are all things that patients are really need and really want to see much more done in these spaces, and are areas where we have seen many cuts. So it's definitely something that I think Charlotte felt that needed to be tackled.
Right, let's hear from Charlotte then.
I'm Charlotte Augst. I've been working in and around health policy for the last 20 or so years, in academia, in Westminster. I worked for healthcare regulators for a while. And most recently, the last 10 or so years, I've been leading coalitions of patient and health and care charities in the voluntary and community sector.
Amazing. So many strings to your bow. So we have a new Labour government. There's been lots of promises throughout the election of what our NHS is going to look like in the coming term of government. There's been a lot of chat about waiting times. There's been a lot of talk about GP appointments. But is that all that patients care about?
I think it's important to recognise that people do care about this. This has political salience because people think of the NHS as a safety net that needs to be placed under their lives so that they can get on and live their lives. Most of us only use the healthcare system very occasionally. And those of us who do only use it occasionally care a lot about access, immediacy of access. All of us who have been in detailed and lengthy contact with the healthcare system, I think also want something else. We don't just want to know that there is a safety net. We also care about the experience we actually have when we need it. And even those of us who only use the system sporadically have experiences that a lot of us find quite troubling. So what people hear very clearly when they ask people about their experiences is that there's really bad communications, very bad care coordination, and an absence of continuity of care, and that those are things that people value a lot. Now, how do we get that experience that only some of us have some of the time onto the political agenda more clearly? I think that's one of the challenges we have as a patient movement, that what we want from the system can feel quite different when we need it a lot, from compared to people who maybe just want to think of it as a safety net that they only want to know is there so that they can live their lives quite untroubled of any health concerns.
Yeah, I think that's so true and so important to think about it in those different ways, because you're right. Most people aren't embedded into these healthcare systems, maybe necessarily as much as we are, as people living with long-term conditions and are so integrated into them. And of all the plans that we've heard about, Labour's plans of what they're going to do now that they're in government to help the NHS, to really support it and rebuild it, do you think any of those plans will work?
I do think we haven't heard all that much about the plans. I do have a sense that in the run-up to the election, the Labour team held their cards quite closely. Rightly, I think the Labour Party has said it will take a long time to fix the NHS, and we will need to design a plan together for what we will do with this service. Most recently, West Streeting has started off this engagement arguably by saying we need to start by acknowledging that the NHS is broken and that it needs both investment and reform. Now, I think we need to get into this conversation, both about investment and about reform. And what the new government needs to enable us to do is to find the right sockets in the system that we can plug our insight and our expertise into. So one thing I think we've got to get right in this is that we give the right status to the knowledge that only patients can bring, and that we then have a realistic conversation about where health services need to sit in a wider ambition around health. The Labour Party have spoken of that they want to be a missions-driven government. So there's an ambition to create much more health for people. And only a part of that can be delivered by the NHS. So how can we get into dialogue both about the wider health framing? How do houses need to look? How do jobs need to look? What do schools need to do? What do communities need to do to create more health? But also, what does the NHS look like in this landscape where it acknowledges it has one important jigsaw piece to play in this wider jigsaw image of health creation, but it needs to do so in partnership with people?
Do you think that's where they should be starting, by really thinking about where they embed people with lived experience of healthcare in their processes and plans?
I was heartened that Wes Streeting's statement used people's experience of the NHS being broken as the yardstick for what needs to happen. I think that kind of realism, that kind of reality check, that we can't answer the question whether the NHS is working by saying we've put 5,000 GPs in or we've created 40,000 appointments. That isn't the answer to the question as to whether the NHS is working. The answer to the question whether the NHS is delivering can only be given by the people who use health and care services, and arguably by the people who work in them. But the people who actually use health and care services are the ones who could say, yes, this was helpful. I now understand what's wrong with my pancreas or my heart valve or my mental health. And I understand what I can do to make myself better. And I understand where services fit into this. I understand the offer and I understand what my role is in all of this. And I don't think that's necessarily really how healthcare delivery is designed towards this outcome. So that's the switch we've got to make. So I think there's, as well as a process argument and a process decision that needs to be made quite quickly, I think the biggest gain will be if we start all design decisions about the NHS by acknowledging that most healthcare happens outside of it, and that it happens in your life and in my life and in everybody's lives, and that some people have what they need to manage their health well and a lot of people don't, and that we need to put this right, and we need to strengthen this tier of healthcare. That's actually primary care. It's what you do when you have a sense that your blood sugar levels are out of control, or what someone else with bipolar disorder does when they realize that maybe they haven't slept well for the last week and they're on a dangerous slide towards a deterioration of their mental health. That's the first tier of healthcare, and that has to be the basic design principle of healthcare. And then we build on top of that, what do formal services need to look like to strengthen this basis, but also then obviously to offer more specialist healthcare when you need it.
Absolutely amazing. Couldn't agree with you more on all of it, Charlotte. Like, it's, yeah, absolutely. And I think let's see what happens now. You know, we can but hope, right?
Practical hope, I think, is what we need. And if I might say one last thing, maybe towards colleagues in my own sector, in the volunteer community sector, would be to say you need to come forward with solutions, and you need to come forward with developed partnerships. These problems we're talking about cannot be resolved by just lobbying government with 35 priority asks. You need to reach out to the other people in your sector and in your topic area who are required to make things better, and then approach the new government by saying, we've got some thoughts here about long-term conditions management, or about end-of-life care, or about young people's mental health, and we've come together to present you with some ideas. I think that's really what's required now, and then I think we have all reason for practical hope.
That was Charlotte Augst. Emma, if I could turn back to you. I mean, two of the words we use here are patients and the public. I mean, why do we make that distinction?
Well, I think Charlotte made a really good point, that often when we're talking about healthcare, we often think about patients that are in the systems, that are using the healthcare service on a regular basis, people living with long-term conditions, people that are really integrated into the systems. And actually what those people want, what patients want, is actually quite different often to what the general public wants. The general public wants from an NHS a safety net, a blanket, something to catch them when they fall. And so their priorities are often quite different to what patients look for when we're talking about the health service.
Okay, and now we have a new government. And do we know any more about Labour's plans for the NHS? Of relevance to patients, of course.
Yeah, I think Charlotte was kind of, again, quite clear that Labour have really kept their cards close to their chest on what their plans are for the NHS and what the priorities will be. We'll see what happens over the next few weeks. But one thing that Charlotte was very kind of clear on is that she felt that it was really important that the Labour government were listening to patients. And when Wes Streeting was appointed, one of his first kind of comments was around that he really had listened to patients, and patients were telling him that the NHS was broken. And I think that hopefully is an indication that they are willing to listen to patients and to take that on board.
Yeah, he's made that very clear. And I suppose the first time it became obvious that the NHS is in crisis. I mean, I think most of us who work closely with the NHS have known this has been an issue predating the pandemic. But to the public, it probably became much more obvious during the pandemic. And unfortunately, the voice of patients and the public was lost during the pandemic. Now that Labour is saying that the post-pandemic, the NHS is now broken, do we have more hope that actually, we are going to have patients heard more constructively and the public as well?
Yeah, I think we have to have hope, because I think in the systems that we have, patients have to be seen as part of the solution. I think, patients, especially those who have lived with long-term conditions, they have a lot of the answers. And I think when we're thinking about how to fix the system, there's a lot in there that we need to tackle, and there's going to be difficult decisions to make. And I think patients have a unique set of skills and expertise that they can bring to that conversation. So yeah, I'm hopeful.
Mm-hmm. One of those solutions is to embed patients and the public in organisations, in healthcare organisations, to make patient and public partnership work properly. And Charlotte, of course, talks about that. What are the key steps to make that happen, Emma?
Well, I think the first thing that they need to do is really just open the door and allow patients to come in. I think it's a bit of a cliche, but giving patients a seat at the table, or just giving them a space to be able to come into an organisation and to really listen to them. I think patients have incredible, unique skills and knowledge of healthcare, and it's really important that organisations invite them in and allow them to be part of that discussion. But then I think the next step is then ensuring that we're involving them across all steps, and making sure that we have diverse voices in the room, making sure that we have their involvement in all that we do across healthcare is also really important as well.
Emma, one interesting topic that came up in the patient issue is something called peer support. And it seems there's a lot of interest in that from a patient perspective, but some reluctance from clinicians and healthcare systems to adopt it.
Yeah, definitely. It's really interesting. So we had this practice education article in the issue on peer support, and now as one of the co-authors. And for us, like for people living with long-term conditions, peer support is such a fundamental element to our care, and that has been for me as well. Being able to talk to other people that live with my condition really helps me managing it day to day. And I think there's often been a fear from healthcare professionals that when you get patients with the same condition, together in a room, that might be a negative thing. And there's a lot of concerns around some of the misinformation, some of the challenges around social media. And so I think it's been a really interesting piece to be able to write about the kind of evidence around peer support as well. So I thought it was best to get a couple of my co-authors on to talk on the podcast. So firstly, we're going to hear from Claire Reid, who's a patient living with type 1 diabetes and a researcher.
I'm Dr. Claire Reid. I'm a qualitative researcher and health services researcher in the Nuffield Department of Primary Care Health Sciences at the University of Oxford. I'm also a psychologist and implementation scientist, and I live with type 1 diabetes. Also, I'm an admin member as well of Sugar Buddies, a peer support group on Facebook.
And you said it's on Facebook. Now, I know there's a lot of concern out there around social media in particular when it comes down to peer support. When you got involved, was that something that you ever worried about?
I did wonder what kind of conversations people were having, if they'd be relevant to me, if they'd be interesting. I wouldn't say I had those concerns myself, but I'm part of the admin team for the group, and we are also moderators. We have a set of rules that we state that we may need to remove posts if they are seen to be giving it like medical advice. But actually, it's very rare that we have to actually action anything. And most of the time, people say themselves, I don't know if that's really good advice. Always go and see your healthcare professional.
And then you are a researcher. You work in this field as well as living in the peer support world. So what's the evidence out there for peer support, or the effectiveness of it, or the impact of it?
Yeah, this is really interesting. The evidence is a little different from things like medication, where you can do a clinical trial. There's a lot of evidence, but a lot of it is very context specific, or like smaller studies, some qualitative studies, which say people really appreciate peer support. It helps with people's quality of life, with their anxiety, help with self-management. So peer support could have had a positive impact, but you can't measure it so clearly as a clinical indicator.
Is there anything else, or is there anything that you would say in particular where peer support really fits with your diabetes care? Like where does that fit with all of the other elements of your care and management that you get?
I'd say it kind of provides some kind of complementary support to the clinical side of it. For one, you feel less alone. You could be managing this condition, hour after hour, day after day on your own. And it's just that kind of connect. It's really easy sometimes to push your condition aside and like focus on other things. It's not always your priority, even if it has a huge impact on your life. But being able to tap in and ask questions, or just say you're feeling stressed, getting some more information, or just being aware of things coming in. So say on the Facebook group, people might post events, discuss ideas, or have meetups, and you sort of gives you the opportunity to like tap back in and, get some more information or support. Or someone might say, oh, I'm really struggling. And then, you can either provide support, which is, it's this amazing feeling actually, or be there yourself and kind of feel like you're not alone, kind of connecting with others. And it's quite powerful really. And it just goes on top of the support you feel you experience from your clinical team.
Yeah, absolutely. And you mentioned as well that the group was kind of created in collaboration with people living with this condition and healthcare professionals. And so, again, in your experience, have you found that that's empowered you to work with your healthcare professionals, or kind of be more involved in care and services? Does that happen within your peer support group?
That's actually a really good point. When I was given this information from the clinical team, I was quite new to the area, new to the service, and really quickly they told me about this group. And I just felt so much more comfortable with them, thinking, oh, wow, okay, they're really interested in me. They're interested in how I feel about my condition. They're interested in connecting with other people. It just felt a bit more holistic. And I felt like they were more open. They weren't putting a barrier, like a clinical barrier between me and them. It was kind of inviting me in and offering other services on top of what they provided. And I've always been really happy with this clinic. They've always given lots of opportunities to connect with them, but somehow it just provided something even more.
And before we have a quick chat about that, Cameron, I also managed to grab Partha, who's the national lead for diabetes for the NHS and a columnist for the BMJ. He was on his travels when we spoke, but he's very passionate about peer support. So he dialed in from Calcutta just before his flight, and he likened peer support to the kind of education that doctors get.
Do you know what the irony is? That for doctors, and I can speak as a doctor, the principle is exactly the same, right? It's not the books or the studies that's making me a better doctor. It's actually, why do we go on conferences? We go on conferences, doctors, because we want to meet our peers, because we want to hear from them what's working, what's not working. So I always say that if that's the principle, so we talk a lot about, oh, we need to learn from each other as doctors and clinicians. We need to learn about good practice. Well, if that's what we want to do for ourselves, why wouldn't you do the same for those living with type 1 diabetes or any chronic disease for that matter?
Yeah, absolutely. It's such a good point, actually, and I've never thought of it that way. So a lot of healthcare professionals really worry about peer support. They really think sometimes that it's going to have some sort of negative impact. What would you say to those doctors or healthcare professionals who are really worried about peer support or advising it?
So I always say to people, what are you worried about? Are you worried about the fact that they might give bad advice? Well, why don't you then be part of the peer support group? Help them understand what's the right thing to give, what's not, listen to what they're saying, give them good advice from your end, be part of it. What's the other worry you have? Is the other worry that, hey, listen, they're going to take my job? Well, then you need to understand that all they're trying to do is make your job easier and better. That's a very important distinction, this is what I keep on saying to people, is that my life as a clinician is infinitely better compared to where it was because we've got peer support groups and I refer people to them. So just as an example, somebody comes to me and says, hey, listen, clinic time's running out, but can I just pick up with you something about like playing football? And my straight away response is, have you heard of Reid? Because, he's got a group and they go, oh, no. And I go, you need to talk to him. He's got type 1. He's got a sensor. And he will tell you which positions you can put your sensors on so that they're going, suddenly it's a different consultation. And I absolutely can tell you, when I do that, next time they come up, they go like, do you know what? That was brilliant because, Chris and his team is so good at TDFC. And so that's your example of peer support. It's made your life better rather than me having to think about, run out of time. How do I give this person advice? So that's the way it should be working, I think.
I find that really hard to understand why healthcare professionals see peer support as a way of us trying to remove ourselves from their support and care. Because as somebody who lives with type 1 diabetes and has peer support, I think I could never imagine it replacing it because it provides something so different. We need both of those things and they provide very different things.
Yeah, I think there'll be a group of people who want to see more data that it's not unsafe. And I think that's what we need to do. We probably need to show guys, look, we've got this peer support. We need to talk more about it, do more, these sort of stuff, podcasts, blogs and stuff.
But what is the evidence? Is there any evidence out there about peer support?
There actually is. So first of all, I would say that this is also one of the reasons why NHS England have funded and helped create this peer support principles document. And I would encourage everybody to look at it. It touches upon the evidence base and as to why it's not just a nice add-on to have, it's actually an evidence-based intervention. So I think, of course, another plug for that work. But at the end of the day, it's a piece of work that does touch upon relevant evidence to go through for commissioners and clinicians if they need convincing.
One issue that's come up is misinformation. It's a concern. How do we best handle that?
Yeah, it was really interesting chatting to Claire because she manages a peer support group. And what she was saying is that they have moderators on their group. And so often when people post up comments or any sort of ideas on the group, they have these moderators who sort of make sure that they're just checking, giving that information a quick glance over to make sure that it isn't creating anything that's of concern. But I think certainly in my experience and from what Claire shared, a community are often very good at checking misinformation. Anything that you see online, you'll very quickly see patients kind of jumping in there and saying, well, hold on a minute, this isn't right. Or anything healthcare advice related, they automatically will jump in and say, don't come here for this, go to your healthcare professional.
That's good to know. But a lot of that moderation depends on an understanding of the evidence base. What is the evidence base for peer support? Is it strong?
Yeah, I suppose peer support is a really difficult one because it's one of those interventions, as Claire was saying, that it's not something that you can do a very clear-cut randomized controlled trial on. It's really messy. It's really dependent on circumstances, on situations. But there is a larger growing evidence base of peer support. We know a lot more now about peer support, and it definitely alleviates a lot of the fears and concerns around peer support. I think it's much harder to prove the impact or to have any evidence to suggest that it's a good thing. But I think the evidence is certainly growing.
So what is the evidence then that it's a good thing?
So at the moment, a lot of the evidence isn't there to suggest that it's a good thing. We don't have a trial to say that peer support will improve your clinical outcomes. But we have much more anecdotal evidence. We do have much more qualitative evidence to say that it does help people in learning how to manage their conditions.
Thanks, Emma. We started the podcast talking about what the government needs to tackle. We've touched on patients as a resource for making a sustainable healthcare system. And now we're going to talk about bringing all of that together with something called social participation. There's a new WHO resolution on that. But Emma, first of all, tell us, what is social participation?
Well, that's a very good question. And to answer it, I went to an expert on our patient advisory panel who's based in Brazil. And he's really been leading the way in terms of social participation in Brazil. So Mark Barone was actually involved in the WHO resolution. So I asked him to describe what it's all about.
I'm Mark Barone. I'm based in Brazil. I've been working in the diabetes and NCDs in general field for 25 years now. Now I lead the intersectoral forum of NCDs and we call NCCs, actually, non-communicable conditions in Brazil. And I've been involved in different organizations in Brazil and abroad also.
So I wanted to have a chat today about this WHO resolution for social participation. So what is this resolution? What does it mean to you?
So according to the resolution, social participation involves all relevant stakeholders, including local communities, health workers, care workers in health sector, volunteers, civil society organizations, and youth in the design, implementation, and review of universal health coverage. It tries to fix the up-down decision-making process that is very common everywhere. So including the perspectives of the population, the different groups in the society is the big goal. So understanding that universal health coverage is health for the entire population. It's not just for a group. It's not just something that is understood by technicians. Otherwise, you can make a big policy, a big plan, but the plan may not solve the problems that population, that group, that community would have.
So this is like a sort of co-design or co-creation of health that people might be doing sort of every day in clinical practice, but just on a much larger scale.
Yeah, you're totally right. Yeah, that's the idea, that it's not only shared decision with your doctor, or even being a partner of the hospital's board, but also participate in the decision of the policies of what the country will have available for the care of people like you.
So you mentioned that you're in Brazil, and Brazil's one of the kind of leaders in social participation. You've been doing this for a while. Can you give us some examples of where having social participation has maybe changed decisions or allowed the experts that are normally involved in these things to make a different decision than what they might have?
Yeah, well, for me, it's easier to bring some examples from diabetes. For example, in Brazil, we had the incorporation of insulin analogs, and this was thanks to the work in partnership between the people living with diabetes and their organizations, and also the medical society, and getting together and going to the Ministry of Health to show the benefits were real of incorporating the insulin analogs. And then we first successfully incorporated the rapid acting analogs in 2017, and then the long acting analogs in 2019. And a more recent gain, there was the document, the guideline for type 2 diabetes in the public health system was reviewed in Brazil, and we could also participate. And something that we recommended for the Ministry of Health was to add sleep disorders as a risk factor for type 2 diabetes, and to be managed as other traditional risk factors, such as inactivity and unhealthy diet. And we succeeded on that as well. So now sleep disorders are included in the guideline for type 2 diabetes in Brazil.
So what's the significance of this being a WHO resolution?
That the resolution passed, I think it's a huge gain for everyone, for humanity, I would say. Why? Because this resolution brings social participation as a goal, as a commitment for all the countries. So all the member states of WHO and UN, obviously. And not only it calls the countries to commit, but also WHO itself to monitor and to make sure that this is followed, and also to report. So then every 2 years, there is a plan to report the outcomes of this commitment with the resolution.
And I suppose, like all WHO resolutions, the devil will be in the detail of actually implementing this at a country level.
Yeah. I think this aspect is important, because although all the countries committed, because it passed this resolution, so how will it be implemented now? So, and there isn't one single formula that will work for everyone. But anyway, I think it's important to highlight that there are some materials already prepared by WHO that would help countries to implement social participation. So, for example, the social participation handbook that was released, I believe, 2 or 3 years ago, the meaningful engagement of people with NCDs, the framework that was launched last year. So are very useful materials for the countries to start organizing their health systems to guarantee the participation of civil society and other groups in the decisions for policies, programs, and everything in health.
So, that sounds like patient and public partnership embedded in the whole system, which is what you've been asking for. How is evidence evaluated and incorporated into that kind of setup?
Yeah, well, it was really interesting chatting to Mark, because he was giving us some examples there of sort of how they involve the patient and citizen or social perspective alongside a lot of the evidence when they're making these decisions. And I think it's really interesting to see how this can sort of change the way things go, because yes, we absolutely have the evidence, and we really want to make sure that that's the key element that helps us make decisions. But there's also then incorporating that lived experience, and I think sometimes that can be a difficult dynamic to manage.
One of the concerns that we've published on in the BMJ is the influence of commercial interests on patient groups, and which then in turn influences policy generally, not in a good direction. How do we try to mitigate against that?
Well, I think it's a really important point, and I think it's something that we all certainly need to be aware of, because it is a huge concern. And I think often the way to kind of make sure we're managing that is to have an awareness of it. So, obviously in the BMJ we have very strict COI policies, but I think it's really important that we understand where these patient organisations are potentially getting funding from. I think also it's really important that we involve a diverse group of patients or patient organisations whenever we are making decisions. So not just going to one patient or one patient organisations, trying to ensure that we're involving a number of them to get different perspectives and different views.
Yeah, it seems to me that the whole involvement of patients and the public in how we make decisions in healthcare, you can't really argue against that. That has to be the right thing to do. But this point about information is absolutely critical. You want the information to be of high quality. You want it to be free of commercial interests, free of adverse influences. And you don't want it to be misinformation. So you require high quality information that's information that comes with integrity and trust. That's quite a big challenge, Emma.
Yeah, 100%. And that's why, when we said at the start, involving patients is really hard because it is really complex. But I think in the long run, it is important, because regardless of having all of that information and that evidence and that all of that together, if you haven't involved the patient, you can't say for sure that is absolutely going to be the thing that's most impactful and the right thing. And we need to look at how we can mitigate some of these challenges and concerns as we're doing this more and more. So, yeah, lots to be done.
Yeah, and in our, I think it's over 20 years of experience of working with patients, 10 years of working on our patient and public strategy, it's hard to come up with demonstrable outcomes that show benefit. We can show better process outcomes. We publish more articles, we get more articles peer reviewed by patients, we involve our patient panel more. We can demonstrate those process measures I think reasonably well, and we can show progress in those. A lot of the benefit is in how we feel about the articles, the kind of response we get from readers. And as you said earlier, it is hard work, it takes commitment, it takes resources. But I think from us on the BMJ, it's an emphatic endorsement that the hard work, the effort is absolutely worth it.
Yeah, we believe that it makes what we do better. And as you say, we don't have a numerical outcome to show that, but it's something that we truly believe. And I don't think it's something that we're ever going to change anytime soon anyway.
Emma, thank you. That's it for this week's podcast. Thank you to all of our guests. We'll be back in a fortnight with our next episode, so make sure you've subscribed. All the articles we've discussed are available as ever on bmj.com. I'm Cameron Abbasi. Thanks for listening.